Okay, good morning, everyone, and welcome to the fourth part of the series of the IPLAN IDPH webinar series. This series is made possible from IDPH and the Community Health Assessment and Planning Grant. Today's session will be focused on quality improvement. Note that this session is recorded and it'll be 2 hours today. If we can move on to the next slide. Your training team for today is Lori Call and myself. We are both from the Illinois Public Health Institute. Lori Call is our center director, and I'm the program manager, and we welcome you to today's training. We're going to go ahead and get started at the top of the hour with a really quick introduction. So this is the last in the series, as I noted, and because this is the last in the series, we are in the process of planning for the 2025 training and webinar series. So we would like to get everyone's feedback on what you believe are your health department's needs to prioritize what training topics you'd like to see. So feel free to use a few minutes here. We're going to drop in the chat the training needs assessment survey, and this survey will help us understand what is the important topics pertaining for your health department and for your staff pertaining to the community health assessment, the CHIP, the Community Health Improvement Plan, and other aspects of IPLAN all the way through implementation and monitoring. So everyone feel free to take a second at the beginning of this training to fill out that training needs assessment if you haven't already. If you have already filled it out, that is totally fine, but we'll give them 5 minutes, I believe, Lori.
Yeah, we'll give folks 5 minutes to complete that while other folks are still joining. And we'll just keep letting people in from the waiting room. And I'm not having access to let people in.
Oh, let me fix that. Yes, and if you've just joined us, we just dropped in the chat, and I'll drop it again, our training needs assessment to help us identify the specific topics that you all want to hear about for the 2025 training series. So feel free to open that link if you haven't taken this survey already, and take a couple minutes to fill out that needs assessment.
Thank you. If you're just joining us, we're completing the training needs assessment at the link in the chat.
And we'll give folks another minute to finish up responding to the training needs assessment. And we'll go ahead and get started.
I'm missing about a lot of people.
Okay, I think we can go ahead and get started, Lori, if you're ready.
Okay, great, thank you. Get this training to advance. Okay, great. Well, we're going to kick off today's training on quality improvement in your community health improvement plan with a quick poll with 2 questions. So Samantha will deploy that, and we're asking, what's your level of experience with quality improvement in general? This is all anonymous, so we don't know who's answering. So don't be shy about saying you don't have any experience or little experience. If that's the case, it's okay. That's really what this is designed for anyway. And what is your level of experience with quality improvement related to your community health improvement plan is the second question. And to see that second question, you just scroll the poll down. There is a second question below that first question. And we've had about 18, 20 answer and got 29 on the call. Give you another second here for this. Okay, let's see where we're at here. I'm excited to say we've got couple very experienced folks who can jump in if they want to give some examples or share anything. And then we've got some folks with a little bit of experience and then about 19% reporting no experience in general. And that's just fine. We're going to start with the basics, really basic here. And that number of no experience in using QI with the chip increases to 50%. And then we do have a couple folks who are using QI with their chip and 40% who have a little bit of experience. So that's really great. Thank you for that information. That's helpful as we go throughout. And again, for those of you who do have that experience, we are happy to have you share that. We've got a couple opportunities built in for you to be able to share your experience. So don't be shy. Okay, so it's very blustery today. I can hear that wind whipping. For today's agenda, we're going to just do a quality improvement overview. And that quality improvement overview will include differentiating between QI, quality improvement, quality planning, and quality assurance. So we're going to talk a little bit about each of those, but spend most of the time talking about the process of QI and then applying quality planning and quality improvement to your chip. We'll spend time talking about using those 2 tools within your chip as you plan and as you try to improve that. And then we'll talk a little bit about process improvement, which QI is really focused on um, uh, towards outcome attainment. So I want to differentiate between process measures and outcome measures and help you think about how to select the best process measures because that's how we really know when to apply QI instead of waiting 5 years down the road to see that we didn't attain our outcomes. We've got time for Q&A and we've already done the training needs assessment, but if you haven't had a chance to take it, Samantha will drop that in the chat again for you to take anytime during today's session. All right. And every time I click in something, I lose my ability to advance slides. All right, the learning objectives then for today, by the end of this session, and I know some of you have a lot more expertise, so you may already know how to do these things, but you'll describe how QI can be used to develop and improve the chip. You'll be able to explain the Plan Do Study Act or Plan Do Check Act. We call that a PDSA or a PDCA. Hopefully you'll be able to apply a few basic QI tools to understand root cause analysis and identifying contributing factors to health issues, and then select the most meaningful process measures towards intended outcomes. And like with our past trainings, we do have a few group agreements. Everybody's done really great with these, but we really do encourage you to be brave and share because this is so much more meaningful when we hear real life experiences from you all. And we did not have anyone from peer health departments who was available or wanted to share on the call today. So we would love to hear peer examples. So if you've got one and you have a QI project you'd like to talk about, or some learning related to QI, or integrating that into your chip, we'd love to hear about it. Just send a message to Samantha while I'm presenting, and she'll make sure that I know about it, and we'll have time to factor that in. So we'd love to hear from you. And that's really the biggest thing. We do have some polls throughout today, and a place for, like I said, for sharing and Q&A. And then we also have a small group exercise, and it's really important that folks participate in that, because otherwise you're sitting in a breakout group with only one person, or people who are multitasking and not focused on the able to focus on the activity, and they can't accomplish it. So I'm giving, as a quality improvement from our last training, I'm giving you a heads up that that small group work will be coming up, and we'd love to have you all participate in that. And we're going to have a little bit larger groups than we had last time, so that no one feels too much pressure in those small groups, and everyone has a few people to be able to bounce ideas off of. Okay, so we've heard that's one of the places that the real learning happens, and exploration, and also those peer presentations. So again, don't be shy if you have something to share. Um, I hope you can tell by my smile that I love QI, and I think this is really fun work. It's fun to use the different tools. All of these tools that we're going to be talking about, all of the methods, are things that you can use in everyday meetings, in your work, and everything that you do. You can make meetings more interesting, more structured by using some of these tools when you're problem solving. So I really think about the quality improvement tools a lot as problem solving tools. They can also be decision making tools. They can help you prioritize. There's just a lot of different tools, and some of you may have seen a little book like this laying around your office at some point, the Public Health Memory Jogger. And this is a little book that we used to be hand out years ago. We don't have anymore, but it's just a book of the tools, a handy little pocket guide in how to, what tools are available for QI, and what their purpose is, whether it's prioritization, data analysis, root cause analysis, whatever it is. And it's just a really nice reference guide. And as you're planning a meeting or an agenda, looking at that to see how you're going to help advance, or what you might use rather than a traditional discussion or a traditional brainstorm, it can give you some ideas of a new structured way of doing something that may yield better results in terms of the output of your discussion. So I really encourage you to check that out. And again, that's called the Public Health Memory Jogger. Okay, so we're going to start off to begin with by talking about quality planning, but we're going to do that in the context of the quality trilogy. And this is also known as the Duran trilogy, from Joseph Duran, who developed this. And it really consists of three primary managerial processes to manage quality within any organization. And remember that quality improvement really comes from manufacturing and healthcare, other fields that we are applying to public health. And quality improvement really became more popular just before public health accreditation came out. And the whole purpose of public health accreditation is quality improvement, is just improving what you're already doing. So, borrowing these tools from other fields and disciplines, we've been able to figure out how to apply them to public health. And sometimes it's a little bit trickier than others, because we're not making widgets in a factory, or we're not prescribing something, or developing a treatment plan for someone to follow, or giving a vaccine or whatever, that we can then measure how that process is really clean and clear, and identify how to improve it. Sometimes our work has a lot more gray area in it. And so that's why we really depend on talking about the trilogy, the quality planning with quality improvement and quality control or quality assurance. So we're going to talk about these three pieces, and in quality planning, you see that there's a cycle. It's really understanding what the needs of the stakeholders or customers, the people that we're serving are. We have to start with understanding those needs, and then we design and pilot a program, a service, an intervention, what have you, to meet the client needs, the customer needs. And then we monitor that impact, how it's going. We measure along the way to see how that's working and what those results are. And then we take some action, based on that. We either um, improve the program and go into a quality improvement phase, or we sustain the gains that we're making if it's working well. So it depends on what happens with those results. So you can see here, imagine that you're implementing a new program here and you've gone through all these stages, you're implementing it and you're measuring your data and everything's looking pretty good in this quality control zone. And then all of a sudden you have a spike in something that's not a good spike. It's something that is unusual. It's a change in the way that your results have been going, and you want to know, hey, what's going on? Maybe this is about restaurant inspections and everybody's been passing and doing well. And then all of a sudden you've got a lot of people who are not passing those inspections and failing in different areas. So you need to take a look and see what's going on, and you want to really understand what's happening, and what's going on with the process to make that change. So when we get into that phase where we're trying to understand, is this an anomaly or is this real? Are we really having a problem that we need to apply QI? And then you go into the quality improvement cycle and you're trying to improve whatever's happening in that process. And so if you are successful, you should see that that spike comes down and it continues going down, and you get into another quality control phase where you're moving along and things are going well. So that's how the three places, or the three different managerial processes, go hand in hand. Again, quality planning provides a system that's capable of meeting the quality standards that have been established based on your customers or whoever you're providing a service to. Quality control is used to determine when corrective action or some type of improvement is needed. And quality improvement seeks better ways of doing things, how we can improve and really get things back on track. So if we're starting with the quality planning, this is just a bigger picture, kind of blows up that visual a little bit so you can see all of the pieces. So quality planning is intended to provide your organization with the means to provide services that can meet those customer and stakeholder needs. And using quality planning methods and tools can improve our overall public health planning. So you have all probably done a lot of quality planning. You've just not called it quality planning, because I'm sure you've conducted assessments to understand the needs related to a particular project or program or something that you're doing, and then you've designed it to meet those needs. And you've done this kind of cycle before, but you probably just haven't said, oh, we're involved in quality planning. It's a piece along the spectrum with quality improvement and quality assurance. When you're using quality planning, you're not just inventing a new program all the time. You're using proven practices and best practices from other health departments, other industries, other sectors. You're being intentional about what methods and tools are used for improvement based on your topic and needs. You're including, developing a solid plan for being able to implement that and also hold the gains, the successes that you've had, so you can maintain that level of quality control. And so our steps, as I said, are identifying who your customers are, internal and external, what their expectations, their needs are, what their requirements are, and developing that program or service to meet and respond to those customer needs. So it's a really important thing that we're not assuming what the customer needs are, but we understand that. So let's take something really simple, like, how customers think about quality improvement. And it might be something like, going through a drive-through for food service. Um, Many times when people are choosing to go through a drive-through, the top thing they're looking for at the drive-through is speed and efficiency. They want it to be fast. So the amount of time they're waiting in that drive-through, they have an expectation of how long they're willing to wait and what is within their requirement. So we need to know what that time is because it may be very different. And that could be the same as waiting in your dental clinic or your health clinic in your waiting room. We don't know what people really require in order to say, okay, this is good customer service, and I will come back here and use that. So understanding what those are and the priority of those services and needs. And then establishing goals and objectives that will meet those specific needs and measure towards those needs. So if I've decided I own a fast food restaurant and I've decided that the wait time in the drive-through line is the most important thing to customers, secondary to maybe quality of the food or temperature of the food or what have you, then that's one thing I'm measuring. I'm measuring how long it takes from the time someone gets to the window to place their order and how long they have that food in their hands. And I have a benchmark related to that I'm trying to accomplish. So think about it like that in the work that you're doing and how you really know if that is meeting your customers' requirements or expectations. And even when things are free, we're providing free services, people are still our customers and they still have expectations. So when we're looking at why is, a certain program not yielding the uptake or people aren't redeeming farmers market coupons at the rate we thought they would or utilizing WIC in the way that we thought, we really need to find out why, and we need to find out what their expectations are around that service to see if we're meeting those or not, because it very well could be that those barriers or those challenges are so much that that's why they're not. Um, After we have established those quality goals and figured out how we're going to measure those, we want to develop a process that can produce those results and then prove that we can sustain that over time, that we can continue to keep that up at that level. So when do you use quality planning over quality assurance or quality improvement? The biggest times where we're using quality planning is when it's a new service or project. So it's never existed before. It's something new that we're doing. We don't know what the customer's expectations are, or we need to find those out because we just have never done that. We've always assumed that we know. Another time that we use quality planning is when the existing service or process is just not meeting the expectations at all. And we need to abandon what we're doing. We need to start over. It's like we need to throw the whole thing out. That's not working. Let's start over with really collecting data and understanding what the needs are around this. Also, if it's something that you do ad hoc, you don't do it all the time, you do it on an infrequent basis. And so that is something you're not doing repetitively over and over and over. You're doing it once in a great moon. So you really need to apply that quality planning to make sure you're still using quality improvement principles as you do that. And if you don't have any performance data to show, baseline data to show whether or not it's working, and being able to get that data would be very time consuming or expensive to collect that, then a lot of times you go back to quality planning to make sure you understand the customer expectations, requirements, and those customers can be internal, they can be external, they can be partners, they can be service recipients, all sorts of things. So we're using customer very broadly. But it would be a time where we just, being able to measure all that we couldn't. So we just kind of go back to quality planning and integrate quality planning into our quality improvement. So that gives you a little bit of understanding about quality planning. So let's take a look at the difference between quality assurance or quality control and quality improvement. So quality assurance is very reactive. It's measuring after the fact. It works on problems after they occur. It's not trying to address or prevent those. A lot of times it's regulatory or by state or federal law. Many times it's led by a management. It's a periodic look back at how we've been doing, might respond to a mandate or crisis of some sort. And a lot of times it's very black and white. It's pass fail. We did that or we didn't do it. And that there are certainly a lot of quality assurance, quality control mechanisms in manufacturing, in healthcare, in other fields. So we want to think about how do we do quality assurance in public health? And I invite you to put in the chat, what's something that you're measuring that would be counted as quality assurance and quality control, and just pop those ideas in the chat. So, what are you doing? What does your health department do that would be that you apply quality control, quality assurance to? And as you're adding those to the chat, I'm going to just take a minute to go over what quality improvement is and how that's different than quality assurance. So, in quality improvement, we're proactively selecting a process to improve. We're not waiting until the end when we say that has just not been working. We're doing it as soon as we find out that something doesn't seem right. We're not doing as well as we could, or we're continually trying to improve results that we have. So we're meeting customer expectations, but not at the level we'd like to. We could do it this even faster. We could do it even better. We could do it more cost effective. Whatever factors you want to measure, you're thinking about there. It quality improvement is used on processes. It seeks to improve. It's part of a culture shift that we're always thinking about ways that we can improve. We're doing formal and informal quality improvement. It's led by staff. It can be led by any level of staff. It does not have to be management led, but it does need support from management. It's intended to be continuous and ongoing, and the purpose is to really meet and exceed expectations. Rebecca has given us an example of quality assurance, and it could be related to how outbreaks are handled, the days to contact, the percent reported, etc. That's a great example. Thank you so much, Rebecca. And if anybody else has any ideas, let us know. Oh, April here. In the past, we've dispersed real-time surveys to judge the drug and mental health issues in the community and how promptly individuals are getting help or resources. So the amount of time that people are waiting to access help or resources, that's a great example as well. Making radon test kits available via online request or payment, and the mailing out of those kits as opposed to requiring a physical visit to us. So that sounds like a great step that you've done in quality improvement to make it easier for folks to be able to access that. And I'm sure that if you're looking at quality assurance, you have probably established a measure around how long it should take for people to request that and then it's shipped out. And so the quality assurance piece would be looking at how long before we send that out. Audits and financial reporting are another quality assurance example. Thank you, Katie. And Melissa says, making sure files are verified, checking to make sure the information is correct and complete in our files. We periodically check files at random to assure quality. Excellent example of quality assurance. And if you are finding an absolute mess and those files are in no way um, uh, include the information and the completeness that you wanted, you'd probably be in a quality improvement situation. Thanks so much for those examples. That's the level of participation I was hoping for, and I'm so grateful for it. Thank you. All right. So here's a poll question for you all to participate in. Thinking about those three different levels, quality assurance, quality improvement, and quality planning, where does your health department spend most of its time? In which of those activities? And it's okay, again, it's anonymous, so we don't know who you are, and we won't ask you to say where you are. No right or wrong answers here. So it's four options: assurance, improvement, planning, or about equal time in all three of those areas. Let us know where you're at there. I'll give you a few more minutes to answer this poll question if you have diverted your attention away for a minute. Okay. Wow, this is great. About 40% of you or 38% of you reporting about equal time. 23% in quality assurance, 15% in QI, and 23% in quality planning. That sounds really about what I would probably guess. So thanks for that. That's great. Again, no right or wrong answers here, and it also has a lot to do with what types of services that you all provide, your level of resources, all of those things. Okay, so we have talked about the three in the quality trilogy, and now we're going to talk specifically about quality improvement. And we're looking at the Institute for Healthcare Improvement's model for improvement. So there are different models that you can use for QI. I have been training on QI and leading quality improvement collaboratives and providing coaching on QI. Um, geez, I don't know, since maybe 2010, so nearly 15 years. And I have almost always used the model for improvement. I think it's easy to understand and follow. And I've adapted a schematic, a flow chart that the Public Health Foundation originally created. And I've made it, I think, easier to use, and it's a great visual. So you'll be able to print it out if you would like and use it as a kind of a poster or something in your office, because I think it's really, really helpful. So I'll show you that in just a bit. We're going to go through it piece by piece. So in the model for improvement, there's really these three main components. What are we trying to accomplish? And when we think about what are we trying to accomplish, that is really the aim statement. An aim statement is just that. What are we trying to improve? What are we ultimately trying to accomplish? What do we want to see? And how will we know that a change is an improvement? That is our data, that we have baseline data and we know how we're going to be measuring that ongoing. And then what changes can we make that will result in an improvement? We are identifying that and figuring that out by using problem analysis or root cause analysis tools. And then those are sort of the big key three, parts going into this. And we are then going through cycles, multiple cycles of the Plan, Do, Study Act. And that is designed to be able to accelerate change. So the Institute for Healthcare Improvement, obviously, they don't have time to see if something is going to reduce infections. They need to be able to do those pretty rapidly, make a change and measure it, make a change and measure it. And so that's why this model is very effective. They're going through these rapid cycles. So we're going to take a little dive into the Plan, Do, Study Act now. So in a nutshell, the Plan, Do, Study Act for learning and improvement, it's really, that is what QI is about. QI is about learning what works, learning what doesn't work. So failure in QI, not achieving the results, is just as important as finding a solution or a fix in a process that does work. Because we document those failures to say, this doesn't work, we measured it, we know why. It's not just somebody saying, oh, that won't work. We know it won't work. We went into it thinking that there was data and all these things pointing to yes, this is a viable solution. But when we tried it, it didn't produce the result that we thought it would. So that learning is just a really important piece of QI. So I just want to emphasize that. So in the Plan, Do, Study Act, it's plan. This is where we're defining what are we trying to accomplish, that aim statement. We're identifying questions to really understand and be able to make predictions. So if we do this, then this will happen. We're making that kind of prediction in that planning stage. We're planning to carry out a cycle. So we're really creating a plan for the whole thing, for the Plan, Do, Study Act. So who's going to be engaged? What are they going to be doing? Where, when, all of that. It's an action plan for the quality improvement. The do stage is when we are actually carrying out the change or the intervention. We're testing that out. We're carrying out the plan. We're documenting the problems, what didn't work, was there some unexpected variation that it worked sometimes, but then it didn't work on others? So maybe you changed something with to reduce wait time and it was working. It was like, oh my gosh, we're getting through this. We're getting patients through quicker and quicker and quicker. And then you start seeing on certain days, they're not going through quicker. What's going on those certain days? And it may be something in the process. Maybe there's something else on those days you do something different. On those days, something else is involved that's impacting the process. So it's figuring out what's happening to cause that variation and that change. So in this do stage, you're starting to do some analysis on what's going on. You're not doing all of your analysis until the next phase, but in the do phase, you're observing, you're looking at what's happening with our implementation. So that reflection, that observation, documenting lessons learned, documenting variation, that's all really important in the do stage. Now, the study stage, this is where we're really doing the analysis of the data. We are measuring what happened. We are completing the analysis of that data and what happened. We're comparing that data to our predictions. If we do this, then this will happen. So was our prediction accurate? Is that what happened? If not, why? So we're summarizing what was learned. We're asking why. We're trying to figure that out. We're using data to do that. And then we go to the decisional phase of ACT. And in the ACT phase, we're saying, okay, we planned and figured out this problem and what's causing the wait time to be so long. We made a change, one change, and we have measured that and monitored that progress. And now we're studying that and understanding some variations. We may even, um, already have learned something that, okay, we've got a great idea about what we need to tweak to make this even better. You may have some of those inklings by the time you get to this decisional stage because you're deciding, are we going to adopt this and standardize this practice because, wow, this is really working? Are we going to adapt it? Do we need to, yes, we're going to do this, but we need to make a tweak. And here's the tweak we're going to do. And we're going to go back and test that tweak, test it with the tweak and see if we got better results. Or we're going to abandon it because it just didn't work. And we're going to learn from it. We're going to document that. We're going to be able to share that with other health departments, but we're going to adopt it and go back to the planning stage. So that's really the cycle. And you set a threshold of what you want to achieve. And if you haven't achieved that with the one intervention or the one change you made, you're doing another cycle. You're doing another cycle and identify what's the next change that we need to make that's going to get us the furthest. So that's the PDSA cycle. And this is the visual that I think is really helpful. Um, I think this lays out all the steps in the Plan, Do, Study Act really clearly. And we're going to go through this one with just a few examples. So I'm going to walk you through this one now. But this is, if you're thinking about, oh, I'd like to have this laid out, this to me is super easy and really clear to understand. So in this first stage of planning, this is where we're identifying and prioritizing opportunities for quality improvement projects. So you're trying to figure out, what do I need to improve? And if you think about this related to your community health improvement plan, you're looking at the things that you and your staff or partners implement that you're measuring. So not the outcomes down the road of 5 years. Did we change heart disease rates, or, not looking at those things that are going to take 20, 30 years, whatever, but you're looking at what are the processes we're doing. Um, and let's take something, for example, that I already talked about, like you're trying to increase fruit and vegetable consumption of your community, fresh fruit and vegetable consumption within your community. And one of your strategies that you're doing is deploying the farmers market double coupon value things. I can't think of what their names are. And you're giving those out, but they're not being turned in. Like, people aren't using them. So you want to figure out how you can get more people to use them. And so increasing the redemption of those farmers market coupons, maybe that's what you're working on. And by the way, I know that data is slow to get back on that particular strategy, so that isn't always a great QI project because of that. But I know that that's something that health departments I've worked with in the past have worked on. So you're brainstorming things related to your chip that you could improve, programs and projects that you're implementing. You're just going to select one at a time because you really want to get skilled in quality improvement before you try spreading it all over. You're first going to develop a problem statement, and that problem statement might start out with that, um, you know, uh, fruit and vegetable, fresh fruit and vegetable coupons are not being redeemed at the level that they're able to be redeemed. Therefore, fruits and vegetables are being wasted, maybe, and people who need fresh fruits and vegetables aren't getting them. So that might be the problem statement. And so you want to then say, how can we increase the redemption rate of fruit and of farmers market coupons among XYZ population? So you want to define that population. So you might prioritize, if your staff, your team wants to start off and you have a lot of different QI projects, you might need to have them prioritize what they're going to work on. So there's different tools that you can use. You can use a 2x2 matrix and say, different factors that you can compare that to, a variety of different things, but you want to choose a project and you want to prioritize those opportunities. So here's some examples of different programs. I gave you one about the farmers market coupons, but there's a whole list here. You might have inaccurate data on something that people have to report. Maybe they're taking too many people are failing inspections. Maybe you are continually being over or underspent on budgets related to some of your chip projects. Maybe something has a really lengthy process time and you need to shorten that, long customer wait times. So there's all kinds of things. Maybe you're not having the people show up to your diabetes prevention programs, or they're not completing the program. Those types of things are perfect for QI projects. And next, we develop an aim statement. So this is what improvement we're trying to seek. It's some sort of measure of change in what, by whom, by when. So it's just a measurable SMART objective. And there's information here on a worksheet for how you would develop an aim statement. You answer briefly, what are we trying to accomplish? How will we know that a change is an improvement? What baseline data do we have or do we need to get? because you have to have baseline data for a QI project. If you do not have baseline data for a QI project, you're really doing quality planning because you have to have baseline data. What changes can we make that will result in improvement? These are the types of things you do to develop an aim statement, and it's just really thinking through those items. Here's some sample aim statements, and these are based on health departments I've worked with in the past. By a certain date, increase the percent of youth ages 18 and younger who will receive preventative dental exams and referrals from blank percent, the baseline, to the desired percent. To raise one or more doses of HPV vaccine coverage levels among a certain age group in certain clinics from baseline to the desired amount. Um, uh, Identify staff timesheets will be submitted on time and error-free, from the baseline. If the baseline was 80%, you want to have 100%, but I think everybody wants that. Another one is reduce the temperature violations during temporary food inspections, and then decrease the number of days from a contract approval to a contract going out the door. So all kinds of projects, but these are actual aim statements from projects that I've supported health departments on in the past. We go on to the next phase here of describing the current process. So describing the current process is we really need to lay out the process. So have any of you used a process diagram, process map, flow charts, swim lane flow charts, any of those types of things? It's really describing what the process is now. And it seems like a really simple task, but it's not always simple because people have different perspectives on how it is. And yes, we'll be sharing all the slides with you along with the recording. So when you think about the process map, you need to pull the people in together who somehow touch or experience this process in some way and have them define the process. If you have a group of people who define it, you need to have other people who touch it also look at it and see, no, that's not how it happens. It goes here first, or it does this, or so-and-so has to make a decision. It sits on this desk for this long, whatever it is, but figure out what that process is. And this is just an example of what one process might look like. I know it's a little bit hard to read on a smaller screen, but you can take a look at it when you get the slides. And these are just the basic flowchart symbols. So this just gives you some guidance on mapping it. But the message is, no matter what tool you use, you need to be able to visually map it out and have all the people who touch it generally agree that that's the process. You want to be able to find out what's going on in this process. And you really want to particularly look at things like bottlenecks, like decision points are typically a good place of a bottleneck where it gets stuck somewhere. So that's something you might want to look at, but you want to get the process as is, not the way it should be, not the way you're supposed to be doing it, not the way you wish it was, but the as is. This is the process we're currently using. And those processes often get really, let's see, complex sometimes when we have a workaround. So say someone who does this one thing was on paternity leave. So while they were on paternity leave, we started doing it this way. And then they never did come back, or they came back in a different role or whatever. But things get really complex for a multitude of reasons. And so we want to track the as is process, not the way it should have been done or the way that the policy says that it's done. We want to track the way it's actually being done. And these are a couple of quotes that I really like about process mapping. You can't begin to improve a process until you understand it, and until you understand it in the way it's being done. not the intended way, but the way it's being done. And you don't learn to process map, you process map to learn. I love that one. So just get in there and figure out what the process is. Okay. So now we're moving on to the fourth sort of major step here, and that's collecting data on the current process. So you're collecting and analyzing data that aligns with the aim statement. What data do you already collect or can you collect to understand the problem? So there's a lot of different tools that you can use to do this, and people who are used to working with data have tools. They can think about different ways to display that data, that baseline data, so that you're understanding what's going on. So I want to talk about one of those tools, which is the Pareto principle and the Pareto chart. So the Pareto principle tells us that 20% of the sources cause 80% of any problem in general. And so we are not looking to fix all the different potential causes of the problem. We're looking for that 20% that are causing 80% of the problem. Okay, so that is why we need to use data and collect data. So if you are looking at, for example, wait time and what's impacting wait time, somebody needs to be tracking what's going on that day. You know, what are the things, what are the variables, what's going on that day. This one is an example from a health department around why do fewer clients in one clinic receive HIV tests than in another. And, you know, they were assuming that it was that people didn't want them in that particular clinic. But when they asked the people, they did a survey, the people who come to the clinic, they found, oh, I didn't touch anything and that went away. Must have breathed on it too hard. When they asked people in the clinic, what they found out was that in that clinic, um, B, it was not offered. No one said, would you like to take an HIV test? We wouldn't have known that if we wouldn't have asked the people who are coming to visit the clinic, the patients or the clients. We would have assumed potentially that the client does not want them, and we would have come up with a whole intervention of how to convince them to have an HIV test. When in fact, all we needed to do was make sure we added into the process or changed in the process or applied quality assurance to ensure that the tests were being offered. So that's a good example and an example of how you use the Pareto principle. The next stage in the plan portion of QI is identifying all possible causes and what are all the causes of this potential problem. So these are the potential causes here that we then used to survey staff. So we're going to go over some of these tools in a bit. So I'm going to just kind of skip over them now. One of them that I use a lot though is a more structured brainstorming where if we're trying to think about all the potential causes of a problem, why are people not showing up? Why do people not finish the diabetes prevention program? Whatever it is, we are asking that question. And this is just a structured brainstorm. I'm sure you've done this before, where people write one idea per post-it note, and then we group the like ideas and then we name them. It's just a structured brainstorming that allows everybody who's on the team to contribute ideas and then to group those. And it's a way that you can then populate the fishbone diagram to be able to put things in the fishbone diagram because you've come up with those areas. So all of these things in this column of the post-it notes were related to processes, and all of the things here were related to policies or providers or whatever. So these categories can change based on what you're doing. This happened to be vaccine coverage in clinics hasn't increased as much as for the HPV vaccine. The uptake hasn't increased as much as it has for Tdap and MCV vaccine coverage. And so they were trying to identify why in this health department. And this is just a blank template for a fishbone diagram where you list the effect or the problem, and then you list all the issues. And I can provide you with a template for a fishbone diagram so you can fill your own in anytime you want. And here's some guidance on this next slide for just some hints and tricks for conducting a fishbone diagram. But again, I'm not going to spend time here because we'll briefly talk about this near the end if we have time. Moving on to the next stage, identify potential improvements. So now we have we've done the fishbone diagram. We figured out what are these potential causes of this problem. And we have narrowed it down to one thing. So maybe it was they're not being offered to have an HIV test. Now we're identifying potential improvements. Is it included in the script? Are we going to put a sign up on the computer? Are we going to have a message pop up on the intake to say, ask the client if they'd like to have an HIV test? What is it that we're going to do to test and see if that makes an improvement? So we're identifying the potential improvements that address the root cause. And I see you, April. Thank you. April says fishbone diagram came in handy with their last IPLAN. Love to hear that. We're going to then develop an improvement theory. So we understand what the root cause is. We have identified some potential improvements and we've narrowed one down. So we're saying if we put a pop-up window on the intake screen that says offer an HIV test, we believe every client will be asked if they would like an HIV test or something like that. I'm making that up. I don't even know if that's something that could happen. So that's your if-then statement, your improvement theory. Then you're going to develop a plan to implement that. We've got to talk to the IT department to get to put that in. We've got to do this. We've got to do that. What are all the steps you have to do? Plan it out. Who's going to do what when to deploy that improvement strategy? That's developing your action plan. Then we're going to implement that. We're going to test that out. We're going to collect data on it, keep collecting data to see if more there's an uptake in HIV tests at that clinic that's pretty much equal to the other one. We're documenting any problems or observations. Maybe sometimes it causes a glitch in the computer system or who knows what. And we're going to look at that data and see what's happening and see if it's making an improvement. And then we're really making a decision here. Did it work? Are we going to adopt it and standardize that as part of a standard operating procedure? Do we need to make a tweak? Are we going to adapt it? Or are we going to abandon it and it didn't work and we're starting over? What are we doing? So that's the QI cycle in a nutshell. And the idea is that we are doing this in rapid cycle improvements. So we are going through the process to make these rapid cycle improvements. We might add that note in the computer, and then we might say that made some improvement. We're going to do this also. So whatever it is that you need to do, but the idea is that so we can continue getting improvement, we're going to implement another improvement. And again, we're looking for those vital few things that cause 80% of the problem. It may not even be, the second one may not even be around offering the test. It may be addressing another problem, like people not understanding what's involved with the test and thinking that it's going to take a long time or something like that, or thinking that they have to pay for it or whatever the case may be. So that is the PDSA and rapid cycle improvement in a nutshell. What we're trying to do are hold the gains. So in that quality control where we've started seeing improvements, we want to sustain and continue those improvements. So you see that going at an up cycle throughout the project. And the more cycles we implement, the more we learn. And the more cycles that we need to implement, it's usually a more difficult problem or project. Oops. Okay. So the rapid cycle improvement, these are short iterative cycles. It's an iterative process. We are trying to hold the gains from one cycle to the next. So, okay, this is working. This is great. I think about it kind of like, think about when you're starting a new January 1, you're starting your new health and fitness and routine and it's so hard to do everything at once, right? It's so hard to do all the stuff at one time. So maybe you start small, like I'm going to eliminate sugar from my diet, right? Let's see how that's working. And then I'm going to add in, more whole foods is my next one. So think about each one of those as a PDSA. You can do it in your own life, not just in the program. But what you want to do is you want to sustain the gains. Or if something's not working, you say, that's not working. So I'm going to abandon that and try something else. So let's pause here and see what your questions, comments are. An example of a QI project that you have led or been part of at your health department, or a challenge or success with QI. So this is a time for you to raise a hand, unmute your line, be able to share in the chat. So we'd love to hear from you. You've already shown us that you're great at participating. So we'd be happy to hear even more. Anyone would like to share or has a question.
Feel free to unmute as well if you'd like.
Surely you're tired of listening. Probably like, let's just get to that small group work. All right. Well, if you have anything, put it in the chat and we will get to that small group work fairly quickly. I'll speed things up a bit here. So the principles of quality improvement here, 6 major principles that I often teach and I learned from Marty Mason, who is just one of the national public health QI gurus that I've had the privilege of working with. The first is that you've got to know your stakeholders, the people who are involved, who are using, benefiting from your program, and understand. You have to know what their needs are, and you're setting your goals and your targets based on those needs. The second is that we are focused on process, not people. So from uh, Deming, the 85-15 rule is that 85% of poor quality is a result of poor work processes, not of staff doing a bad job. So when things aren't working out the way you'd like, you're not seeing the results you want, go back to the process and not the people. And that's often not our first, and I'm guilty of this as well, not our first step. We go back to the people. What aren't folks doing? And so this is just a call for action of looking at the processes. And I mentioned that processes often go wrong at decision-making points or at a handoff point, and that processes sometimes end up being the result of a workaround. So let's look at an example that is from a health department I worked with many years ago. Is a real example of people versus process. And this was a public health emergency response program. They're probably using different strategies right now, but they had a decline in the employee call down response. So it was back in 2010. And the theory was that people just were not responding to the calls. And you can see the data here that of the people who acknowledged the calls in blue versus people available to assemble. And so they were having, pretty good results. But look here in October, it really dropped. The acknowledgement of the call really dropped. The available to assemble dropped a little bit. And so they really had to look and go back and look at processes, but they were ready to say, what, and probably did say in the health department, what's going on? Why are people not answering? And responding. And when they did start asking staff, staff were saying, particularly on the management team, were saying, we did that, we answered, I don't know what's going on. So they went and looked and checked their assumptions. And by looking at the process, the system that they were using was not accurately capturing the data any longer. They had so they were having a lack of understanding about the program. So you can see here where it had dropped down, it went back up, and they were able to continually go up and sustain those gains for longer. So change in the system improved and sustained that improvement. Oops, and I'm going to go back to these principles really quick. The next one is using data for decisions, and I mentioned that you have to have data for it to be a quality improvement project. If you don't, you're definitely doing quality planning because you're collecting that baseline data to see where are we at right now, or after you've implemented something. You really want to know where are we at. We don't know if it's an improvement without data. It's just a change unless we have data to be able to prove that it was an improvement. So we want to be able to set that aim statement and use that data. Data is used in the aim statement. It's used in problem analysis. It's used in so many different places. So it's a really critical piece to all of this. Next is using teamwork to improve the work. So QI efforts need buy-in from all stakeholders. We want creative ideas. We want to be able to divide the labor across multiple people. The solution often affects many different people and their roles and their time. Processes are often cross-functional. So we want to make sure that we're involving this, and this is a team project and work. Quality improvement is not necessarily an individual task. Making quality improvement continuous, we're using the conclusions from data analysis to identify areas for improvement. We are charging, training, and supporting our QI teams to do this, and they're implementing multiple cycles of the PDSA. And then finally, QI is not successful without demonstrated leadership commitment and support. So rewarding improvements, recognizing and showing storyboards and what the QI projects have done and being able to call that out, even if there's failures, what they learned from that failure. Connecting quality improvement to your strategic plan and your performance improvement system, knowing how to use the principles and how to build a QI culture, all those sorts of things. But without an infrastructure to support QI, it becomes just a random activity and not embedded in your organization. So, skip that. We're going to move into the next section so we can jump into the activity and spend some time in group together. And what we'll be talking about here is developing the chip with QI and thinking about QI. So Samantha's going to drop in the chat a worksheet that NACHO developed on QI on the chip, NACHO's project charter template. And we're not going to use it as a project charter today, but we're going to use it as some of the pieces and things that you think about. So the first part of the document is on background and context. So you're listing what the chip priority area is. You're describing the problem related to that priority area. This is just like if you had an action team together to focus on a priority. These are the types of things they would do if they were creating a charter around this. They're going to list, a few key data points that show this problem. They're describing the related social and structural determinants. They're describing the current systems and processes that contribute to that, and looking at the intervention levels. Um, and and then the next page here, they're also looking at how you will know that a change is an improvement. So, or I'm sorry, they're looking at what are we trying to accomplish in those are the next sections. So the project description. So we've had the problem description, and now the project description is what are we going to do about it? And who do we need on this team? Might be internal and external folks. And then finally, the last part is how will we know that a change is an improvement? So what are we going to be measuring ultimately, and what's our aim statement? And what changes can we make? So what are the stakeholder needs related to this? What are the drivers and the root causes? What are some change ideas? What are the process metrics? And what are the balance metrics? And balance metrics are things that you might measure to be able to make sure there are no unintended consequences with that intervention. And that if you have unintended consequences, that you're catching that right away and you're able to understand that. So I think about, like some programs, if people are getting, if they're making so much money, then they're ineligible for this program, and then they've lost their childcare or whatever the case may be. That might be an unintended consequence that you didn't, that they needed more funding, or they needed this or they needed that, but you didn't know if they had more funding, it was going to prevent them from having a service that they need, like childcare. And that's just an example. It's not real in any way. I'm just throwing that out there as a potential unintended consequence. So you want to think about what those unintended consequences are, and you would want to then be able to say, how are we going to measure whether or not there are any unintended consequences? That's what that number 14 is really talking about. So I want you all to take a look at that worksheet. You can open it up in another browser, or whatever you need to do to open that document. I think it's a Word doc. So you're just opening your Word doc. And we're going to go into breakout groups. And in the breakout groups, you are going to, Samantha, how many groups are we going to have?
We are going to have 5 breakout groups.
5 breakout groups. Okay. Okay, let's all work on uh food insecurity. We'll just work on that one topic in the community. So ensuring that, everybody in the community has the food that they need, healthy food, um, for every day, to have the 3 meals a day or whatever meals that they need every day that are culturally appropriate, healthy foods. So we're working on food insecurity. And just assume that you all are from the same type of area. You whatever from your community, you can inform as part of that. We're just doing a play along. And the purpose of this is really, I want you just to kind of explore questions 1 through 6 on your issue. You may not know all the answers, and don't spend too much time on 1, 2, and 3. Well, one is just one is the easy one. You're going to put food insecurity for number 1, but you don't have to put data points and all this. Just in general, put a couple things that would help describe what's going on, um, and answer the questions 2 through 6. Focus most of your time on 4, 5, and 6, and we're going to start out with 15 minutes and see how that goes. And if we need to add 5 more minutes, we'll do that. But we're going to put the description of what we're asking you to do in. This is another quality improvement for us. In the chat for each of you, when you break out into your rooms, we'll make sure it's in your chat. But the only instruction is, as a small group, you're working on food insecurity, and you're answering the questions in the worksheet as best you can for questions 2 through 6. And whoever's name starts, the first name starts with the closest letter to A in the alphabet, will be the person that's kind of asking the questions and making sure that you're staying on track. And the person whose name is next in the alphabet. So if your name starts with a B, A or B, you would be first. If your name starts with a C or D, and you'd be second. So number two, you're going to, if the group wants to type up and just record a few of those things, you can record those and share your screen if you want. But you don't have to, there's no requirement. You're just doing questions, just talking about those questions because I want you to think about how you can use this with your chip. Okay? Does anybody have any questions on what we're going to do in the next 15 to 20 minutes? All right, Samantha, I'm going to stop sharing. And if you wouldn't mind putting everybody in breakout groups.
Yes. A couple quick notes. If you are in a group and there's nobody there, you should be able to move back to the main room or notify me and let me know, and I can move you to another room. If you have any issues, feel free to notify me at any time. And I'm gonna drop the note in the chat, and feel free to download the handout as well. So I'm going to open all rooms now. It looks like we're about 6 people per room.
Great. Everybody's coming back now. And I need to share my screen again. I'm not sharing, am I?
Nope.
Okay. Share. Oh my gosh, I've just messed it all up. Do you see the slide?
Yes, and it says debrief.
Yeah, I can.
Okay, thanks. Okay, thank you. So I just want to hear now just how was this experience for you starting in on that worksheet? Could you see your health department using it? Why or why not? So what did you think about that worksheet just starting to explore the problem? If I could hear from a couple groups. So how about somebody from group one?
Hey, Lori, I took notes for group one. I'm sorry, what were you asking
Um,
again?
yeah, just how was the experience for you, and could you see your health department using this tool?
Oh, in general, yeah, I definitely could once we get to the improvement plan part of our whole child chip.
Great, great. So it was worthwhile, and you could see you using that.
Yeah, definitely.
Thanks, Dolores. How about
You're
another
welcome.
group? Anything you liked in particular about it, or that you found helpful that you could be using in your chip?
This is Steve. I don't know what group number we're in, but I think it's a nice exercise to go through, given, the appropriate amount of time. It certainly is comprehensive, and you're looking forward at the same time you're looking back and developing a baseline. So I think it really helps you organize your thoughts, and it's comprehensive enough to where if you have a good group of people participating here, I think you could squeeze out a lot of great information.
Oh, thanks so much, Steve. Great. Yeah, I really like the tool. I think it can be a really nice supplement. And so thanks everybody for spending some time in community together talking about that. And I wanted to just touch on the parts that we didn't get to. We didn't get to the parts around setting your aim statement and, what the root causes are. And I want to keep in mind one thing on this. This tool is intended to be a charter, so it's a place that you document everything. It doesn't mean that everything is sequentially the way you would do it. So, a lot of times you may set an aim statement, but once you do a root cause analysis or you look at your baseline data, you may need to modify that aim statement. So these things are somewhat in order, but you may need to go back to different stages and change things. It's a way to be able to organize and capture the information and the exploration and the types of activities that you'd be doing if you're integrating QI into your planning. And I think many of you already do these steps. It's just really putting a tool and a name to it all. So the pieces that are on here that we didn't get to, and I said we mentioned them earlier, we talk about them, are kind of this really, the drivers and the root causes and those sorts of things. So let's take a look at a couple quick tools here. And someone had mentioned in the chat that the fishbone diagram was really helpful. And I think some of you who probably have used IPLAN for a really long time, you're used to that, what I always call like the NCAA March Madness brackets. They kind of look like that. But it's a direct and indirect contributing factors. It's a problem analysis tool looking at the direct and indirect contributing factors. So similar to the root cause analysis, you're looking for what is it about, what is it that contributes to this problem and makes this a bigger problem? And what is it that makes it a bigger problem here? So really looking at that local context. You're looking at risk factors when you're looking at that direct and indirect contributing factors, and then what impacts the level of risk in your area. So all of these tools are really just understanding the problem, and you want to be able to, as we mentioned, understand those vital few. What is contributing the most to that problem? So in food insecurity, I want you to be thinking about right now, what are those underlying root causes to food insecurity? And you could do this through a fishbone diagram. You could have people brainstorm in an affinity diagram with all those post-it notes and list all the causes to food insecurity and then name each cause and plug them into this. Or here's another tool. My screen just went black. Another tool that I have used in the last couple years with Trinity Health System, who I've been working with across the country to lead some social determinants of health programs and projects. And we're looking at a root cause analysis where it's very similar. You're looking at the problem or the issue, and then you're looking at what's that underlying root cause or what's that condition that is contributing to that. So again, direct and indirect contributing factors. And then you're asking why here? And that may help describe a social or institutional inequity that is exacerbating that issue. So if you think about food insecurity in the communities that you have been talking about, what is contributing to food insecurity? You can just throw some things in the chat. What are the root causes to food insecurity? People not having access to fresh and healthy food, or food at all, but definitely healthy food. What are some of those contributing factors? And just put one or two in the chat so we can do this exercise here. Limited money to buy food, transportation of being able to get to food, climate and weather, lack of public transportation. Okay, so if we think about, let's just think about the transportation and being able to get to the food. If you were thinking about locally in your community, you're trying to say, why is that a bigger problem here? Some of the things that you might answer is there's not public transportation to get where that is. It's a rural location. People have disabilities. The built environment makes it so that it's not safe to be able to walk or to get there. There may be an insurmountable amount of things to where you're starting to look at, well, what do we do about this? Are we turning this into a transportation initiative? Or are we looking at how can we, for temporarily, you know, um, do something to meet the need and get food directly to them, bring the food to them? Or are we looking at a longer range solution or both of how can we get sustainable food right local in the community or address the transportation challenges. So you're really looking through this to identify all those potential causes and asking why here. What is it that it's about here? It may be something along the lines of some institutional or structural policy or barrier that is preventing businesses from being able to develop or be in a certain area. And then you've got a policy strategy as opposed to something else. For something like food, we always have the issue of making sure that people, this immediate need of we can't stop feeding people to figure out how to do this large long-term solution or be able to address poverty. But we do need to be working on both, right? We need to be ensuring that people have food right now, but we also need to be working more upstream and addressing why people don't have food in the first place. And so using this root cause analysis tool and digging in there can help identify both of those things. So I encourage you to kind of explore and play around with it. The other piece I wanted to share is when people come up with something and maybe they say there is a lack of public transportation. And you would say, why is there a lack of public transportation here? And only people who live in that community may be able to answer that. Why, and just keep asking why and digging deeper until you get to something that is really the root cause and the underlying issue that needs to be addressed. And oftentimes those are structural barriers that need to change. And they require policy systems and environmental change strategies. These aren't things that require just setting up another food, you know, farmers market coupon redemption program or bringing food there. They require real systems level change that includes policy and environmental change. So I encourage you to explore using these tools, but even when you're doing any problem analysis, this 5 Whys tool to dig deeper into understanding the problem is really helpful. And it's not always just saying, why, but, elaborating on that a little bit. Well, tell me why there's, been a history of no public transportation in this community, or tell me why the grocery stores have closed in this area, or whatever the case may be. But really exploring that, and if you need to pause and get some data or talk to some other folks, do that, but don't stop asking why until you can get down to those root causes and see that the solutions that we need to implement are often being part of a much larger systems change initiative to address these structural barriers. Okay. The last thing that I want to cover in our time, and we just have about 5 minutes to do this, so I think we have enough time to do this, is to talk about process versus outcome and to really look at process improvement versus outcome improvement. And so no matter what you're implementing, what you end up doing and implementing as your strategies, you need to be measuring what you're doing to know if what you're doing is the right things, right? When we're looking at that quality planning and quality assurance, quality control, in that quality control, we're the only way we know we have quality assurance is if we're measuring what it is we're doing. So process measures are about measuring what you and your staff and your partners do to implement a strategy or intervention. So it answers, um, uh, are we doing the right things? I'm sorry. Are we doing things right? Are we doing things right? It's telling us if we're doing them right. Outcome measures are the impact or the results of those things that we're doing. So they often end up being what our clients or customers do, or the impact on them or the impact on the community. So are we doing the right things? That's what that answers. When we are often for grants and other things only asked to submit outcome measures. And many times those outcome measures can't be seen or achieved in the time that we have a project. Even for our IPLAN for 5 years, we're asked to list impact and outcome objectives. Same thing, right? They're just different ranges of time for the IPLAN. But we also need to be thinking about what are the process measures that we're going to measure and monitor to see if we are on track, if we're implementing this the right way. Are we on track? Or is it likely that we're going to achieve that outcome? So if you're trying to do something like policy change, you have to think about, what would I measure to see if we are going in the right direction here? How many meetings are we having with policymakers? How many meetings have policymakers attended, or how many listening sessions have they attended? What do you need to be measuring to know if you're moving in the right direction here, if you're implementing the right kinds of things? Not just did we get this policy passed or not, because that's too long, but are we going in the right direction? So I want to encourage you to start really thinking about choosing the most meaningful process measures. Everyone puts so much weight into outcome measures, and they're really, really important, but we're never going to achieve those outcome measures if we don't measure our process. So for a lot of programs and projects, we measure things like attendance and participation and completion rates, um, satisfaction, how much did they like it? Um, what we planned in the agenda, is that what we ended up delivering or talking about during the meeting? Or did it get hijacked and we completely talked about something else? Is it, what's the cost ratio? Are we staying within budget? What's the staffing level that it takes? How many people are, we able to serve with that staffing level? What's our dissemination or distribution rate of whatever it is, whether it's vaccines or radon kits or whatever it is? What's the level of community engagement that we needed for this to pass this policy? Which groups have we been able to engage? So really thinking about the projects that you're measuring and what will give you the best data to say if you're doing the right things. So if you do have a diabetes prevention program, let's say, there are a couple things that quickly come to mind besides tracking, health measures related to that, which would be outcome measures, but also thinking about, it would be important what percentage of people completed whatever is completed of that course. If it's, I can't remember how many weeks that course is, but it's so long. Let's just say it's 15 weeks and people need to complete 90% of that. What percentage of people completed 90%? And was the content delivered the same as content planned? It seems like those would be a couple really important measures in order to understand whether or not the intervention you're really measuring that intervention the way it's intended, especially for evidence-based programs. And most evidence-based programs suggest some process measures and suggest process measures that are important if you're implementing that project with fidelity. So I just wanted to leave you with that process measures really often get ignored, like they're not that important, but they are so important because if we're not measuring these things, we can't apply quality improvement to improve our retention rates or our attendance and participation rates or community engagement rates or whether or not we're delivering something with the efficacy of the program, those types of things. And we can't even begin to measure the outcome of whether or not it's going to make a difference because we're not implementing the strategy at the best of its possible intention to have the likelihood of achieving that outcome. So particularly for things that have a long range outcome, these process measures are absolutely essential. And oftentimes they don't cost anything to measure. They're things that you should count and measure that are important to understanding the level at which you're implementing that program, project, strategy accurately, effectively, not just what's important to someone else for a grant or what have you that they might want you to measure. So I just wanted to leave you with that. I'm really passionate about process measures too, but this is where we apply QI, is on these process measures to improve this process. So I hope you have been able to walk away with something useful here. We will send you the worksheet that you worked on today, as well as a template for a fishbone diagram. And you will also get the slides and the recording. Is there anything else that you would like, you need, you want to ask about, or a question? Feel free to drop that into the chat now. And as you're dropping your question or unmuting your line to ask a question, Samantha is going to close us out.
Thank you so much, Lori. Thank you all for your participation today. This was really excellent to hear from you all, and your experience and your thoughts and opinions. I am dropping a few things in the chat here. So the first thing I'm dropping, if you weren't able to join us at the beginning of the training, we have a training needs assessment out right now. This will help us inform what we want to work on next year. So if you want to take a few minutes to respond to that, it closes end of day today. I'm also dropping our training evaluation. We want to know how we can improve, how we can do better, what we can work on for next year. So please let us know your thoughts and feelings and opinions in the training evaluation. And finally, we have one more session left. We have a group technical assistance session on December 4th, and that will be a really great Q&A with IDPH data stewards. So thank you so much. We will be resending these links out following this training to get more responses from you all. But if you could take the last couple minutes and respond to the evaluation and the assessment survey, that would be lovely. We thank you so much and have a great rest of your day.
Thanks, everyone.
Thank you.
Happy Thanksgiving to everyone.
Yes, happy Thanksgiving. Thank you.